Hello everybody, we are now onto the St Luke's version, thus now pink. I have to say I feel slightly ridiculous talking to you about end-of-life care at home because obviously you guys do most of it. My name's Hannah McLaughlin, I'm one of the community consultants at St Luke's. I suspect you know most of this, but it's just kind of an update about what the community team are doing with medicines. In case there's anything you don't know, feel free to stop me for questions if you want to, or at the end there's quite a lot to get through. And I talk very quickly, so I apologise for that. So that's what we're trying to do. I'm going to go through the various symptoms, talk about the normal medicines, then talk about the medicines that the palliative care team might use and when to call us. The guidelines that we're going off are from 2015, nice guidelines. Obviously not a lot has changed since then, but they are very, very old. Since then, there's been the ambitions framework and One Chance to Get It Right, which I'm sure you've all seen. And essentially, it comes down to recognising that a person is in the last days of life, talking to them and their families about it, which we do, trying to come up with shared decision making between them, their families, their carers, whoever's involved in that person's care. They've been really, really specific about hydration and nutrition because that's one of the big downfallings of the Liverpool care pathway was, once you're on the LCP, you can't eat and drink, which wasn't true, but that's what was kind of recognised in the media and what families thought about. And then talking about those symptoms that matter to people when they're dying. And they specifically talk about pain, breathlessness, nausea and vomiting, noisy respiratory secretions and agitation, because those are the things that we can do something about. They're very common, lots of people get them. And they worry families. And if you're talking to people about what are you worried about as you're dying, that will often come up. People sort of assume everybody must die in pain because that's what TV tells them. So it's really busy. It's just to explain these are the kind of symptoms that you see when people are dying. So they can be really, really varied. For pain, it ranges from about a third of patients to about 90% of patients die with pain. But what's really important there is a third of patients don't have any pain at all when they're dying, just the same as most people don't have anything at all when they're living. So it's really down to the individual, and you don't have to get any of these symptoms, but equally, if you've got someone dying at home, they can be very symptomatic. So again, it gets forgotten a little bit, but any kind of symptom at end of life, you treat it the same as you would do anything else. So you take a history, examine the patient, try and work out what's causing the problem, rather than just give everybody morphine and midazolam at the same time, because that's what everybody gets when they're dying on a pink card. I understand why it happens. I understand especially why the district nurses do it overnight, because it means you're trying to treat what you're trying to treat and you don't necessarily have to come back, and there's not very many of them, but it's really, really unhelpful for them when you're trying to work out what to do in the daytime with them and how to treat them going forward. So the first thing to talk about is pain, because it's really, really common and it's the thing that people worry about. So trying to look at your patient and think, well, why did they have pain last week? So why are they probably going to have pain this week? If you've got someone with osteoarthritis that was normally really, really well managed on paracetamol, now they're dying, they can't take it, why are we not still just giving them paracetamol? You can have a liquid, you can have a PR, that might be all that they need. Thinking about the non-pharmacological things, so what kind of position are they in? Do they need a hospital bed? Do they need a different mattress? Everybody knows the hospital mattresses and the hospital beds you get at home aren't very, very comfortable, but trying things like that. Different rise recliner chairs, you can get them from S&4Cs. They're a brilliant charity and they have a few of them. They can lend them out to end-of-life care patients. So is there something different we can do that isn't just medication? Thinking about bowels and bladder, we regularly go and see people at home that have had repeated doses of morphine for pain, and actually they're lying on their catheter tube, and if you move their leg off the catheter tube, they're not in pain anymore. Lots of you are making faces, but it happens all of the time. If you can, thinking about emotional pain for patients. Obviously, if people can't speak to you, you can't really explore it, but actually there are a lot of patients that can. And when they're distressed, it gets put down as pain, and family members tell you that they're in pain, they get painkillers, but actually they're not in pain, they're just really upset, they're scared, they want to talk to you about things. The other thing to be aware of is if you go and see a person that looks completely comfortable and the family members are telling you they're in pain, actually who's in pain? Is it the patient or is it the family? And is it painkillers that they need, or is it somebody to sit down, talk through with them and explain what's going on? And if you do that, can you avoid trying to give them some medication? Obviously, it's very easy for me to say that when I have a long time to go and sit in people's houses. I appreciate you don't have that time, but it's not necessarily the GP that needs to do it. There's lots of other people in your practice, lots of other people that can support them. So going down to the medications, because that's what I'm meant to be talking about, the standard thing we use is morphine or oxycodone. So it's a broad-acting analgesic, it works on immune receptors, it's really, really good, and more importantly, it can be given subcut, which is why we use it so much. I hope you've all seen the Sheffield Palliative Care and End-of-Life Guidelines. They've got dose suggestions for them. Essentially, you start low and you work up, because it's very easy to give people more medication. It's quite hard to give them less if you're giving them too much. We go with morphine as standard because it's cheap. Everybody has it. Most of the pharmacies will have it. But if you've got somebody that has poor renal failure, so an eGFR of about 30 and below, we would say use oxycodone. And again, it's no more expensive nowadays. It's very easy to get. We don't use diamorphine because we don't want the district nurses or people not used to it using diamorphine and morphine simultaneously and getting it wrong. But there have been occasions where we've used diamorphine because you just can't get enough in a syringe driver, and then we'd switch to diamorphine. But if you're doing that, I would make sure that everybody is very aware that they've got that in the house and it's not morphine. The other kind of normal opioids that we use in palliative care that you might see is something called fentanyl. So we use it because it's not renally excreted. We will put it in syringe drivers, but we won't use it as a PRN medication because it only works for about 30, 40 minutes. So if you've got a district nurse that's taken 40 minutes to get there, and then they give a subcut of fentanyl, 40 minutes later it's worn off and the family are calling them again. So we tend to use oxycodone for that, and then fentanyl in the driver, so it doesn't accumulate, doesn't cause many problems. If you're needing to do that, I'd give the palliative care team a ring because we can talk you through the dose conversions. We can also tell you where to get it in the city because it's not something your local chemist will have, and occasionally we need to get it from the hospital pharmacy. So it's the same for methadone. You will see patients on methadone in syringe drivers in community, especially if that's the medication that they've had long term. Methadone dose conversion is quite tricky and it's quite person specific. So again, if you've got anybody needing to convert, if you call the palliative care team, talk it through with us, we'll probably want to go out and see them as well. We should know most of the patients already on methadone for pain control. We won't know some of the patients on it for drug replacement, but often likewise will call us if they're needing to convert it, or we should probably know them for their end-of-life care already. There are pharmacies across the city that hold methadone, you can get access to it 7 days a week. The WIC is the big one that will always have some, but again, if they're struggling, you can get it from the hospital pharmacy, so you can get it. The other things are slightly more interesting from a pain point of view. So one medicine everybody always forgets for pain is Buscopan. It's brilliant. It works really, really well for any kind of bowel spasmy type pain or bladder spasmy type pain. So if you've got somebody who actually, the problem is constipation or bowel obstruction, and that's what's causing the pain, Buscopan will probably work much better for them than an opioid would. It's super, super cheap. It doesn't make them sleepy, and you can get it in a syringe drive very, very easily. 20 milligrams over 24 hours doesn't do very much. So if you're starting for pain control, think about 120 or 180, that kind of dose. It is incredibly constipating and it will dry them out completely, just like my mouth is dry right now. So you might need to think about mouth care, explain to patients and families they'll need ice, stuff like that at the same time, but it's a brilliant medication. I love it. The other things you might have seen us using more of in the community are NSAIDs. So Ketorolac was our kind of old school one that everybody knows and we can get very easily. It's a COX-1, COX-2 inhibitor. You can use it PRN. We tend to put it in a driver just because you don't find the nurses giving it very much PRN because they don't know it. But we are also using Paracoxib more now as well. It's a little bit safer. They use it a lot in the trust, so you'll often see people discharged on it. Thank you. It's quite hard to get in community, so if you've got patients on it, it'll take a couple of days for the wicker to get stock in and actually give it out to patients, so it's not the kind of one that you can get on a Saturday morning. You sort of can, but it involves going to the trust and it's a lot of organising and sorting. So if you've got patients on it or you're thinking about using it for patients, please do ring us, tell us, talk it through with us, and we'll try and make sure that you've got a supply coming. Symptom. I should say it's off licence, like most of the things we do. But it's really, really well recognised in palliative care now, so you do use it. The other medication that we use a lot for pain is clonazepam. So it's a benzodiazepine. The rationale behind it is it's a muscle relaxant. So if you've got somebody very stiff with pain, they're stiffening everything up. If you can relax their muscles, it can often make them feel better. There is a suggestion that it's a neuropathic agent as well. Opinions differ as to how true that is, but it's definitely a muscle relaxant, so it will definitely help with that. You can get it orally, and it works just as well orally as it does subcut. So there's some patients that will have it as a teeny tiny oral tablet as well. It's very sedating, and you will have six-foot men that have like 125 micrograms and then are asleep for a day and a half. Equally, you'll get 95-year-olds that have a bucket of it and it doesn't seem to do anything to them. So just very definitely with this, start small, work up. If you're using it as a PRN medication, it takes a lot longer to have an effect than oral morphine, for example. So warning families that will take an hour for it to do anything means that they're not then recalling people after half an hour. So the next big symptom that we get called about a lot is anxiety, agitation, or delirium. It all kind of gets grouped together, but actually they're very, very different things, and trying to understand what's causing the problem can be really, really helpful to work out how to treat it. So we talked a lot about dementia already. So obviously anybody who is a bit confused or demented, when they're dying, they'll probably still be a bit confused and demented. That is different to somebody who's agitated because they're so scared about dying, but it all gets treated exactly the same. Everybody gets a bit of midazolam. So trying to work out what's causing it can be really helpful. All the kind of normal delirium things you would do, so keep the lights on, hearing aids, music, all that kind of thing. Again, like I said, if you can, talk to people about what's causing the worry, what's upsetting them. Talking to the family about it as well can be helpful. I'm obsessed with when was the last time they pooed. But if they haven't pooed for 2 weeks and they're constantly grabbing at the tummy, they probably just need a suppository rather than some haloperidol. And this is very palliative care-y, and I am wearing a cardigan, but if you've got somebody that's very, very spiritual or very religious, and there are certain things that they have to have done for them before they die, and that's not been done, actually, is that the thing that we need to do? So we've had patients in hospital where we've got the rabbi in, they've said some prayers, and everything has calmed down beautifully. So just having a little think about that as well, if you can. For family members, agitation and delirium is probably the worst thing that they can have to manage at home. If you've got somebody constantly getting up and down, they're really scared, they're really worried, just having somebody in the house with them is really, really helpful. And I'm sure you refer to intensive home nurses a lot, but they are absolutely fabulous. They're not nurses, they're carers. I don't understand why they're called that, but they come in, they're really experienced, they look after people who are dying at home all of the time, and they are so, so calm and lovely, and sit with family members and just talk them through what's normal. The wife, the partner can go off and have a sleep for 3 or 4 hours or however long they manage, and then when they come back, everything just seems a little bit better. So trying to refer to them and get them involved early if you can is brilliant. They can be in the house 24 hours a day, but they can also just come a couple of times a week for those people that are dying over several weeks. And just a couple of nights of decent sleep a week will often get family members out of a pickle. So, having said that, medications are also used a lot, obviously. If you've got somebody that's anxious rather than delirious, we go for a benzodiazepine. So we all use midazolam, we use it a lot, start small, work up. We don't tend to use oral benzodiazepines that much because I think we just sort of forget that you can. So lorazepam can be given sublingually, and it's easy enough to get some sublingual under somebody's tongue if they're not able to swallow it. The brands to use are Genus, that's the one that we normally have in Sheffield, but it's been out of stock for a couple of weeks. So PVL and Teva are also able to be used sublingually. They're not licensed, but they do work. It should take 15 to 20 minutes for it to have an effect, and it normally calms people down. Again, start with a low dose, work up if you need to. I normally say 2 milligrams max as a starting dose, but it's in the air. If you've got someone that needs 2.5, 3, 4, that's absolutely fine. It's what works for them. If you've got somebody that's delirious rather than anxious and scared, actually using an antipsychotic is much better, because you're then treating or managing the delirium rather than just making them a bit sleepy. We use haloperidol a lot in Sheffield because we use it for nausea as well, and it comes up on your little thing when you do for end-of-life care meds. It's broad-acting, it's sedating, which can be quite helpful in the middle of the night, but we use a slightly higher dose for delirium than we would do for nausea. So I think nausea you start at 0.5 in the guidelines, but for delirium I'd give at least 1.5, maybe 3 milligrams. In Sheffield, we've said go up to 5 milligrams before thinking about switching, but in other places they do use much higher doses. So Chesterfield will go up to 10, I think some places go up to 15 or 20, it kind of depends on your local area. Really importantly, don't use them in people with Parkinson's, because obviously it'll make their Parkinson's worse. If you're trying haloperidol and it's not working, the first thing is actually something else causing the bother. Do you need to think about something else? If it's not that, and you do just need to give them a broader-acting antipsychotic, the one we use in Sheffield is levomepromazine, again, because it's easy to get, it's very, very cheap, and it's very small volume. It does work for nausea as well, and some of your patients will have it for nausea, but if you're using it for delirium, we, again, give a bigger dose, so 12.5 to 25 milligrams, and you can push that right up to 200 milligrams to sedate somebody if you need to. If you're getting to sort of 50, 75, I would be speaking to the palliative care team, probably speaking to them before that as well, because if it's not working, we need to have a plan B for what's going to happen, especially if it's over the weekend. And some of the plan B medicines are quite hard to get your hands on, so we need to be trying to get them in early. The next thing to think about is nausea and vomiting. This is the one symptom that if you've got somebody dying at home and their main problem is nausea and vomiting, if hypercalcemia could be the thing that's causing this, actually for those patients I'd probably say it's worth doing some blood tests, because hypercalcemia looks like dying until you decide it's hypercalcemia and you treat them and then they magically get better. That's not magic, but you know, it's medications. Patients with hypercalcemia, some of them, it rebounds back very quickly after a week or two, but actually there are a lot that are well for sort of 3, 4, 5 months afterwards, maybe with repeated treatment, but are really well with good quality of life. The other reasons that you get bowel nausea and vomiting end of life, the big thing is bowel obstruction, and the reason it's important is because you manage it slightly differently to the nausea and vomiting not caused by bowel obstruction. So for bowel obstruction, it's a broad-acting antiemetic, but you try and reduce the volume of vomit that they're having. So that's why we use buscopan and octreotide and things that try and dry up secretions. And if you've got something that's causing a blockage, would steroids be helpful in reducing that blockage? And if they would, you need to give the steroids subcut, otherwise they won't get anywhere, they won't get to the thing to treat it. If it's not bowel obstruction, are they constipated? Do they need a suppository? I love suppositories. And again, broad-acting antiemetic. There is no point giving people oral medications if they're vomiting them up, but we often see people given oral antiemetics who then immediately vomit them back. Sublingual, maybe, but definitely not oral. For nausea and vomiting, what we tend to use in Sheffield is haloperidol. It's cheap, it's easy to get, and it's generally well tolerated. And like I said, we use a slightly lower dose. If haloperidol's not working, the next one we go for is levomepromazine, because again, it's cheap and it's available. The other things to think about though are ondansetron, and that's probably what I'd go for if you've got a patient with Parkinson's disease. It is really constipating though, so if constipation is causing the problem and then you give them ondansetron to help the problem, you get into this horrible, horrible cycle. If you've got someone with large volumes of vomit or large volumes of stuff in their stomach, buscopan can be really, really helpful in drying that up a little bit. And if you dry out the amount of secretion, you will reduce the amount of times they vomit. So that's why we'd use it. And it's why we use it in bowel obstruction. Metoclopramide, domperidone, they're all prokinetics and can be quite helpful. Domperidone you can't give subcut, which is why we tend to go for metoclopramide. And then, like I said, for patients in bowel obstruction, some steroids can be helpful. If you're prescribing dexamethasone subcut, we'll ask you to prescribe 3.3 in a ml because you don't have to keep it in the fridge, whereas the 3.8 you do have to keep in the fridge, which is why we're specific. But again, it sometimes goes out of stock, which is why we sometimes ask you to prescribe the other dose. So respiratory secretions are, again, something that families and patients worry about. We try not to call it death rattle anymore because it scares people, and because a lot of our head and neck patients and MND patients will have it way before they start dying. So if they think they've got a death rattle, but actually they've got 6-month prognosis, it can be quite upsetting for them. Trying to explain to patients and families that they're not choking, they're not drowning, it's not pulmonary edema, this is just normal airway secretions that you're not swallowing or you're not coughing and clearing because they're not bothering them anymore, is really important. If you can explain and if you can teach families how to reposition a patient, actually that will deal with a lot of respiratory secretions without having to give them medication. Please don't suction them, because if you think when you're at the dentist and you get suctioned, it just reaccumulates straight away. But nursing homes love suctioning them. And trying to understand as well that the buscopan that we use to treat it doesn't dry up the secretions that are already there. It just tries to stop secretions accumulating. So families expect you to be given a medicine and then the secretions go away completely. That won't happen. It takes time for the medicine to get into your system and for things to dry up. It's best to give it in a syringe driver as a 24-hour dose. And if you're going to do that, start at least 60, 80, 20 milligrams over 24 hours. There's absolutely nothing. So please don't do that. We've gone for buscopan in Sheffield because it doesn't cross your blood-brain barrier, it doesn't make you sleepy, but places still do use hyaluronidine hydrobromide specifically because it does make you sleepy, and sometimes that's really helpful. And glycopronium is the other one that you'll sometimes use in Sheffield, and again, it can make you a little bit sleepy. It's really, really constipating and it dries your mouth up. So the last thing to talk about is breathlessness. General patients don't tend to get breathless at end of life. It tends to be people with respiratory problems, with effusions, heart failure, that sort of thing. So it's not something that people will necessarily say they're worried about unless they have ILD, for example. The most important thing with breathlessness is actually, is it bothering the patient? Because you can get lots of people that are blue with a really high rest rate, but they're not bothered by it because they've been like that the whole time. All the normal things that you would do for any other patient, you can do them for dying people as well. So sit them up. Do they need to get one of those rise recliner chairs from SM4Cs? All the square breathing techniques that the physios do. Try and move air across their muzzle. So open your windows, use your fan, and then oxygen. Because I've been specifically asked to talk to you about oxygen. So for normal breathlessness, you can use opioids, exactly the same as you would do for pain. Very small dose, work up if you need to. Again, we tend to use morphine because it's cheap. Large doses can reduce the respiratory effort, but that's not what we're going for. There's really good evidence up to about 20 milligrams of morphine over 24 hours is completely safe in COPD patients, even ones that have had an IV before. It can also be useful in patients with heart failure, and we use it a lot for them as well, because it offloads the heart a little bit. Specifically for patients that are anxious with their breathlessness, benzodiazepines can be useful, but it's not what I'd use first. I'd probably use opiates first, and then consider benzos second, and only if they're helpful. If they're not helpful, stop them, because they're not going to be helpful. Again, it's probably palliative care that would start this, but for heart failure patients, you can give furosemide in a syringe driver as well. You get to about 200 milligrams in 24 hours. You can give more, but it just means you've got 2 syringe drivers, which is quite annoying. It's quite hard to get injectable furosemide in community, so that's probably why you'd be speaking to us. And if you're going to do it, make sure they've got a catheter in, because we can't give it kind of as a BD dose. You have to do it 24 hours, and obviously they'll be peeing for 24 hours. Very, very occasionally, you might bring somebody into the hospice and actually cannulate them to give them IV furosemide, but we don't normally do it. And because of the waiting list, we don't normally have space when you need them to come in, which is a problem. So I've been asked to speak about oxygen for palliation, and I phoned the oxygen nurses to check what I'm allowed to say and what I'm not meant to say. So this is from them. So it's helpful for hypoxic patients, but it's absolutely not helpful for patients who are not hypoxic. They like it because it feels nice and it feels like you've got air getting into you, but it actually doesn't offer them any benefit other than placebo. If they're not hypoxic, it's fan therapy, opening windows, and you absolutely need to make sure that they are not a CO2 retainer before you prescribe it. If you're worried about them or think a patient needs oxygen that you've been told can't have oxygen, the oxygen service have a weekly MDT every Wednesday, and they want you to speak to them beforehand because they can discuss it. And the things that they're worried about are safety issues. So if you've got dementia patients who are smoking, absolutely cannot have it. People that live in houses of multiple occupancy and flats, so any kind of worries there. And people who are known CO2 retainers or have needed NIV in the past. If your patient is none of those things, then you can absolutely prescribe them oxygen at end of life. So you need to do 3 forms to do it. There's a HOOF form, a consent form to share information, and a safety form that goes through things like, have they got a fire alarm in the house? Is it a gas stove or an electric stove? Is anybody a smoker? That sort of thing. It's on the SDH intranet page and it's on the GP Press portal as well. Whenever I try to click it, it doesn't work, but I think it works for you guys. It's just because I'm not GP. So anybody who's a prescriber can prescribe concentrators for 24-hour day use. You can't prescribe ambulatory and you can't prescribe a cylinder, and the palliative care team can't do that either. If your patient needs any of those things, you need to be going to the oxygen nurses. They will review them and they will prescribe it for us. Anybody that's been prescribed oxygen palliatively will get a leaflet sent out from the oxygen nurses to explain to them how to use it for symptom control. And then they get a routine follow-up at 3 months, with the assumption that most of the patients who are prescribed oxygen for palliative care probably won't have that follow-up at 3 months because they will have already died. But it's also a kind of check-in as to who's getting this longer term. That's the oxygen nurses' numbers, but I didn't put the thing in. They very, very much want you to ring them, and they said they've got a voicemail. If you phone them and they don't pick it up, leave them a voicemail and they'll call you back. And their lead clinician is Dr. Lawson, and he's very good at replying to emails as well. So if you've got any questions, just email them. So the last thing to talk about, because Lynn has asked me to, but I can't see Lynn. She's there. Pink cards for use across Sheffield. So you've probably noticed they've been revised in June last year. On page 2 and 3 of them, they've got really, really helpful information about how to use the pink cards, but also things for the slightly more interesting medicines like ketorolac, octreotide, that sort of thing, what you mix them in, because it's not always water. And also a little bit about what mixes with what. You can have 3 drugs maximum in a syringe driver in Sheffield. For people that work outside of Sheffield or have done, you absolutely can put more in a syringe driver, but they've decided, that you can only put 3 in. Equally, you can only fill it up to 22 mils, and it's the way that the syringe driver has been set up in Sheffield, just from a safety point of view. They want you to write in black pen and capitals, please. And if you're crossing things through, cross them through like that. The other 2 pages, and I've broken this now, are the subcut medications and the oral medication PRN side for the intensive home nurses or for the other carers to use. Have any of you ever filled in for the intensive home nurses or prescribed it for them? So you can do. What you need to make sure is, because they're carers and not nurses, they're not allowed to calculate a dose. So when you're prescribing it, you have to prescribe what the patient will actually take. So oral morphine, the solution, concentration, the dose, but then specifically what the carer will give them. And if you've got all that there, the carers will give medications out of hours off a pink card, which means they've got something to give them while they're waiting for the evening and nights nurses to come, which is really, really helpful. And I think that's me done.